All right. So I know that we are just kind of getting started with our ATA 2026 Tinnitus Awareness Week seminar. We've got some folks kind of trickling in here, so we're going to take a couple minutes to let everyone kind of get out of the waiting room and into their virtual chairs. But just as kind of to warm us up here, I know we've got three wonderful panelists that I'll be introducing here in just a moment. And we are really excited to talk about kind of this overall picture of providing the right care at the right place at the right time with tinnitus and sound sensitivity disorders, although we will be focusing more on tinnitus today. Um, so in general, what we'll see today is that we're not trying to promote one best model. It's really trying to get an understanding of, where people are at, where they need to go, and how we can get them there through this process in a more kind of efficient way. For those of you who will be doing some follow-up reading, Jim Henry, who I'll introduce in a moment, has a recent publication on a tinnitus stepped care model. That might be something that kind of comes up as we go through our discussion today, and then something you might want to follow up on after we're all concluded. But this is something that kind of helps us maybe think about progressing through that care efficiently. So we'll talk about that today too. Um, so in general, I think maybe most folks are on, so we'll kind of get started here. We're gonna kind of focus on general education today. So feel free to use the Q&A to submit any questions that you have into that area, and we'll do our best to get to all of them, although I know there are going to be lots of questions. So try to keep that to kind of more general questions so we can make sure we address them. So just to jump in, my name's Rebecca Lewis. I'm moderating the session today. I'm an audiologist, a researcher. I'm over at UCSF in San Francisco as chief of audiology. And I am really excited to introduce our three panelists today because they represent different areas of our tinnitus care spectrum. And I think they each have something that is really kind of different to offer to this conversation, and I'm really excited to actually kind of hear them interact. So I think hopefully you are too. So I will first just ask our great speakers here to introduce themselves. First with kind of the setting you're most familiar with, who might be in that setting, what kind of patients you might see, and then one thing that you wish every tinnitus patient knew. And Jim, I'm going to start with you because I already kind of mentioned you earlier. Maybe you could start with just an introduction and kind of where you come from.
Well, thank you, Becky, and glad to be here and joining everyone. And hello, everyone out there, wherever you are. I worked at the VA hospital in Portland for over 35 years as an auditory researcher. I did my dissertation work and my doctoral studies in the lab of Dr. Jack Vernon and Mary Meikle, and that's what got me interested in tinnitus. And I ended up writing a grant about tinnitus, and after I finished school, and then I did tinnitus research ever since. I retired over 3 years ago, but I just kind of continued my career on my own by writing a series of books. I do some consultations, I do presentations, and I'm involved with the ATA and everything they're doing, and I totally support what they're doing. So that's me, and I'm happy to be here and look forward to the conversation.
Thank you so much, Jim. We're delighted that you're here, and yeah, I'm very excited to kind of have everyone kind of chat through things together. I will pass it over to Sarah, Dr. Downs. If you would mind just introducing yourselves, tell us a little bit about your practice and yeah, kind of who you're seeing today. Oh, and then you're muted, just as a
All right, how about now?
perfect.
Okay, good. Yeah, well, I'm Sarah Downs. I'm an audiologist in northern Minnesota, and I'm in private practice. So we have 5 different locations, and we specialize in tinnitus and sound sensitivity. And so my group of, but I see people of all ages, uh, and so I guess what was the last part of the question?
Oh yeah,
Oh, sorry,
and
sorry.
I've
Oh,
layered it on. Yeah.
yeah.
And in fact, I'm kind of curious, especially since you see tinnitus patients of all ages, what is one thing you wish every tinnitus patient knew, maybe even regardless of age?
Yeah, so I think the one thing that I wish everybody knew is that um, there's hope, there's help out there for tinnitus, and unfortunately, I think a lot of people are told that there's nothing that can be done about tinnitus, but there's just so much that we can do, and that they don't have to go through it by themselves. Um, so
That's, yeah, a very good reminder. And I think we'll hear themes of that today too. So,
yeah,
yes, thank you
yeah,
so much.
yeah,
And yeah, thank you for joining us as well today.
sure.
I'll rely on first names today, but Dr. Downs, Sarah.
Okay, thank you.
And then, yeah, last but not least, I would love to introduce my colleague actually at UCSF, Dr. Hobbs. Greg, if you would mind just introducing yourself, tell us a little bit about UCSF and kind of what type of patients you see there.
Yeah, so I'm Greg Hobbs. I'm a doctor of audiology at UCSF. That's University of California, San Francisco. We see as an audiology practice, we see wide range of patients. I'm on the adult side mainly, but for tinnitus, I do see youth, and I have my colleagues over at Mission Bay and at the pediatric clinic, so they send some of their patients over. But we see population and demographic wise, we see people ranging from people on Medicaid, homeless, county jail, all the way to executives of Fortune 500 companies and things. So it's a very wide demographic. We have a lot of people coming with different languages. We work with in-person interpreters, and so we see quite the spectrum of cases.
Yeah, no, that's great. Thank you. And I'm curious, maybe thinking about that spectrum of, demographics. Is there something that you wish you could tell all of your patients today, even if they've seen you before? What is one thing that maybe you wish every tinnitus patient knew?
I want to kind of second what Sarah said that there is stuff we can do. There is a hope. It doesn't have to be a spiral, and there is information, good information out there. There's some information not to pay attention to, but and that we understand that it's kind of hard to navigate because there is so much out there. The internet figured out very quickly what I do for work, because I get all the spam and the ads that everybody else gets. But there is good information out there, and just finding the resources. Yeah.
Yeah, yeah. And finding the resources can be kind of challenging. So I think we will touch on that a little bit later. But when in doubt, the ATA is there as a resource for quality information. So make sure that if you have questions, feel free to visit that website. So I'm curious, across these different settings, you have, a wide spectrum of ages, demographics, people coming from all different places. And so I'm curious about how that might affect what success looks like for a tinnitus patient. So maybe I'll come back to Sarah. In your practice, is how do you define success for a patient? And is that something that really depends on the patient, or is there a certain bar that you can kind of apply for everybody?
Thank you. So I would say that bar is different for each patient depending on what areas of their life that the tinnitus is impacting, right? So um, in our practice, we use a patient-directed approach to tinnitus. And so we use the Hallam's four stages of habituation as a kind of our guideposts of how treatment is going along from people who have are impacted in very many different ways. Their tinnitus is really intrusive, and going through that habituation process to where it's not intrusive and it's something that they can easily ignore. And so successful treatment to me is when people can move through that, and they are usually the ones that tell me when they're done with treatment and when they're ready to move on and they feel they have the tools they need. And in our, in our clinic, that usually takes 10 to 12 weeks on average. So
Nice. Yeah, that's great. Yeah, and I imagine, people do have different kind of starting points, and so being able to individualize, their care to make sure you kind of see them across that journey is really important. It does remind me, I'm going to toss it over to Jim. It does remind me about trying to kind of think about your stepped care model and trying to identify maybe where someone should go in that step model. So I wonder, Jim, could you tell us a little bit more about this, step care model that you published last year, and maybe what success looks like for a patient who might go through that using that model of care. Um, we'll yeah, we'll touch on more later, of course. So just a quick
Yeah,
overview is
I'll go
great.
briefly. I totally agree with what Sarah just said about success, and success is defined differently for different patients. Different patients have different needs, and the bottom line is, have their needs been met? And the step care model says they need to at first have their hearing evaluated and a brief tinnitus assessment to determine, do they have hearing loss, do they maybe need hearing aids, and how much of a problem is their tinnitus, and then do they have sound sensitivity concerns. And so their needs may be met just by doing that. And they walk out the door and they've had their hearing evaluated. Okay, maybe they don't have hearing loss, or tinnitus really isn't that much of a problem. That's success. And then you can work your way up to the different steps. Well, okay, maybe their tinnitus is really bothersome and they need treatment. Well, the model says first educate the patient, and I didn't answer the question, what do I think patients need more than anything? I would say they need education. They need good information, quality information about tinnitus. What is it? Why is it a problem? How does it become a problem? What can be done about it? And they need to stay off of the internet and stay off of all the sites that are trying to sell them stuff. And don't just buy into an expensive treatment right off the bat. Get educated first. And then once you're educated, then decide if you need treatment, and if so, what kind of treatment. And then that opens the door to a lot of different possibilities. And we could just list through all these different treatment methods, and I won't do that. But that usually takes care of people if they're bothered by tinnitus and their lives are upended. And it gets them back on track. And I would say success is technically habituation. And if they've fully habituated to their tinnitus, that means they're not thinking about it most of the time. And when they do think about it, they're not reacting to it. That is really success. And that's what treatment is supposed to accomplish. But it can be accomplished earlier, at earlier stages. Now, if they don't achieve habituation, they may need further services. There may be more other issues going on. And that's where the next step would be. They need to be evaluated by a psychologist and an audiologist in depth. So they may have had a more a lightweight evaluation early on just to determine what their needs were. But now you need to figure out, okay, you've had all this treatment, you've had all this education, you've had your hearing evaluated, maybe you have hearing aids, but your life is still significantly impacted by your tinnitus. Now you need that full comprehensive evaluation. And then based on that comprehensive evaluation, then you can move on to any number of treatments that are out there, no matter what they are. And if the person has the means and the willingness to spend the money, there's a lot of opportunities. There's no proof that any one method works better than any other. So in general, I advocate for sort of a minimalist approach to just do the bare minimum and see how that works, and then do more if you need more.
Mm-hmm. Yeah, I think so many things that I think all of us agree with on that one. And I can't help but think that Greg might have a natural response to this because I know that education is something that you focus on in your practice, and we've even seen some good outcomes just with education alone. So I'm curious, Greg, what does that bring up for you?
Yeah. And just to second everything everybody's said, I endorse all of that. To go back to kind of the original question and my thoughts on what Jim and Sarah said, success is an interesting thing. When I am not a licensed psychologist, I just want to make that clear to everybody. I'm a doctor of audiology. But I've had experience in that world. And one of the things that they say is like moving towards your value. Like you don't achieve a value, you just move towards your value. And habituation is like the ultimate goal. That's like the ultimate success, where we treat tinnitus like we would our shirt, where we're not actively thinking about our shirt, or we're not trying to distract ourselves from our shirt. And we can kind of come in and out of habituation from time to time. And I've experienced that with my own tinnitus as well. So there's kinds of, so I wanted to kind of think about like internally, what do I think about success and what that is? In that it could be as simple as seeing someone's like body language change over the course of counseling. There's often a moment where you could see just like the arms kind of come down, or just some kind of understanding. And I think education is a part of that. There's a lot of people tend to come in more so now than ever in the past. People come in with a lot of information of things that they read online, and when I train like our externs, I tell them a lot of times it's just connecting dots for people, and tying everything together so that they kind of get a better understanding. And I do think that education is a strong part, and just sharing that information, and from things that we know. And I always say we don't know everything. There's always more to learn, but we do know a lot, and we can share that.
Absolutely. Yeah, well said. Um, yeah, I was kind of I feel like Sarah was kind of engaging so much in what you were saying, Greg, that I kind of want to toss it back to her if she's got a quick follow-up comment, but we can also move to a next question. Sarah, did you have a thought there? And that's okay if not.
Yeah, no, I'm just agreeing. I think that we just really have to start where people are at. And I was nodding about the body language because I'm also certified in mind body medicine. And so whenever I'm talking to people who have tinnitus, I'm always also looking for cues about, or clues, I should say, about what other parts of their nervous system are really engaged in their experience of tinnitus. And I've seen the shoulders relax at times when we've connected a dot where they understand, oh, tinnitus is not something scary. It's maybe not a something that's so mysterious that my nervous system is going to grab onto it in a fight or flight way, and that we can regard it as neutral, so we can, that part of the nervous system can let go. And you see that sometimes once they connect the dot for themselves about why their tinnitus has become intrusive, and they can,
Yeah.
what through the just the general education piece, they often can start unwinding that part that
Yeah.
got attached.
Yeah, absolutely. And I'm curious because you talk about this fight or flight instinct, and sometimes if someone's, kind of coming in hot, and they're kind of wound up a little bit, how can you approach that first visit, to ensure that you're really touching on, the really baseline required things that you need to do. Jim touched on some of them earlier, like a hearing evaluation, but also making sure that, the patient doesn't feel like, oh, you're disregarding my tinnitus, you're only thinking about my hearing, and they might be very focused on that tinnitus. I'm kind of curious how we balance what is needed in that first visit with, especially if someone's feeling, kind of high up on the ladder, kind of activated in that way. And Sarah, you've got the mind body medicine approach, so maybe I'll toss it back to you, and then I'll
Okay.
move on.
Uh, so I think, first of all, whenever we're trying to discover how somebody's tinnitus went, how it came about, we have to do a really thorough auditory assessment, because we know that it's usually something going on in the auditory system that is the setup for tinnitus, right? So we want to really understand their auditory system and do a really thorough examination so that we can have some facts, right? So it's, a lot of it is um, demystifying this thing that started to happen, this tinnitus that appeared. And we want to find out what is the underlying mechanism for that tinnitus. And so a lot of times that's the first piece of really individualized information that the patient needs to be able to start working with their own tinnitus. And then, you know, we really we look at we're talking about the first examination. We're looking at the TFI. We want to find out what parts of their life are being impacted by the tinnitus. So that'll help me know if, we've got sleep disturbance going on, if we've got concentration going on, if it's, a hearing and communication piece that's really getting in the way with their tinnitus. And that'll help me to make really good recommendations about what kind of interventions would be helpful. Uh, and then you asked about the mind body piece. I guess, do
It
you want
might
to pause for
I
a second?
might
Let somebody
I
else
might
go?
kind of twist that a little bit. Yeah, because you're talking about the TFI, which is a patient-reported outcome measure,
Yeah.
and something that I think, a lot of clinics use, and especially in this way to identify these components to follow up on. I guess if you're getting that TFI information, does that change how you would approach that first visit? For example, if they have a very high TFI score, might you approach that first visit a little bit differently than if they have a moderate to low TFI score?
Back to me again. Okay.
Oh, I don't have to keep focusing
No,
on you. I'm
no, that's
sorry.
okay. I'm happy to go. So yes, in that it will steer our conversation. So
Yes.
if they're not having any trouble about sleep, I'm not gonna focus on that. I'm gonna focus where they're struggling. And so if they're not having trouble with sleep, I'm not gonna talk about it. But if it's concentration or being able to enjoy quiet or socializing, those are the things that I'm going to try to focus on. It kind of goes back to what Jim was saying. We got to kind of meet people where they're at
Mhm.
and give them the tools that are needed for the moment or for that individual.
Definitely.
Mm-hmm.
Yeah, yeah. No, that's
Yeah.
great. Thank you.
Yeah.
And then I might actually toss it over to Greg, because you're making sure that you give them the tools that they need to meet them where they're at. Are there any kind of red flags that you would look for to go, oh, well, actually, given that you are kind of sharing, this particular feature with me, I might actually make a referral back to primary care or to an ENT, or maybe I don't know if you would treat a hearing aid evaluation as separate, but that could be a separate referral, I suppose. Um,
That's a really good question. And there are a lot of situations that can result in kind of redirecting. So to start with the last thing you said, sometimes we have different kind of levels of and keeping with the theme of step care, levels of tinnitus counseling. So at our clinic, we have a hearing test. People will often come in, they'll say, I have bothersome tinnitus, or they were referred for a hearing test because they have bothersome tinnitus. The audiologist can then counsel there. We have a group sessions that has tinnitus information. Then there's the one-on-one counseling. We have 90-minute visits that where we, do the tinnitus counseling portion. By that time, sometimes we catch things like if there's like an asymmetry or pulsatile tinnitus or things like that, then we involve ENT because we do look for flags. I think that's the importance of starting with the evaluation is that we do look for things that require more than just the education aspect, whether that's like something on their hearing test that makes us, go, oh, ENT might want to do head imaging or something like that. Especially with like sound sensitivities can come with other pathologies. So it's we always look for those flags. So by the time they get to a counseling session with myself, a lot of those flags have been kind of accounted for. However, there are people who um, will show up. Like I had someone from out of state came to California for tinnitus counseling at our clinic, and she had a middle ear myoclonus. And so as she was discussing her symptoms, there was a moment where I was like, time out for a second and let me explore this a little bit. And then she ended up I ended up writing a report for her to take back to her ENT. She ended up getting a second ENT visit for more options, and then ended up with treatment for the myoclonus, which was kind of the right avenue for her, rather than the kind of the baseline constant tinnitus, because I think the myoclonus was the most disruptive thing in her life. And until we kind of resolve some of those disruptive things, it's hard to kind of manage, limbic system responses to tinnitus and things because this thing is happening to them. So yeah, I would say there's a lot of moments where we do, but that's the nice thing about being in this position is we've been trained to know how to redirect. So that's something that like a lot of internet resources don't quite know how to
Mm.
manage, including AI like ChatGPT. Because I have a lot of people who come in and they say, well, ChatGPT told me, XYZ. And I'm not saying it's a bad tool, but it is incomplete information. So it's good, that they have someone to ask.
Yeah, yeah. You've touched on a lot of important points. And Jim, I'm going to toss it to you next because one thing that I'm seeing in some of our questions, and then one thing that Greg has kind of underlined is, at some point you have, accounted for whatever red flags you've kind of gone through your tinnitus counseling. And, I had someone in the chat who said, well, I've had tinnitus for, 29 years and now I'm habituated to it. Do I need to continue to see a tinnitus specialist as an audiologist? Like, is that something that I would then need to continue, or could someone be kind of, released to more of a less specialized audiologist for tinnitus? Jim, do you see kind of a model for that in the VA system, or do they tend to kind of stick within this tinnitus specialist route once they've habituated?
Uh, let's see, how do I answer that? Um, one thing is each person is individual and has individual needs, and that's the nice thing about the Tinnitus Functional Index, the TFI, is it does categorize these different areas where tinnitus can be a problem. We call them domains of tinnitus distress, and it may be a sleep problem. And if it's primarily a sleep problem, at the VA we develop progressive.
Oh, I'm not sure what happened, but your sound just cut out. I wonder if there's a connection. Uh, oh no. Okay. Uh, would you mind trying to say a couple more words there? Maybe
While we
I'll
wait for Jim,
toss it to Greg. Yeah.
it's and Jim, cut me off as soon as we get your audio back, please. Um, but and I don't know where I want to hear Jim's answer too, because I would
Yeah.
love to know how he was going to answer about habituation. There are different domains in the TFI, so there's different kind of categories, and if there is a certain category, I would probably redo a TFI and see, because I've had some people who redo their TFI and their domain of what is the most problematic thing might change over time. And then they might need to be redirected. I've had people with sleep disturbances that weren't necessarily just in regards to the tinnitus, but other issues as well. So that's something that they could seek help for. But the I think my most common response when people are like, "Oh yeah, I've had bothersome tinnitus," but I think I don't notice it a whole lot. I tend to go great, and let us know if you need more questions because I don't want to necessarily disrupt a pathway. I had someone I looked at their like 10-year history and it was like ENT, audiologist, 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 ENT, ENT. And then I saw him 10 years later and for a routine hearing test. And I was like, how's your hearing? It's about the same. Any ringing in your ears? No. And then like I zipped my lip and was just like, great, you know,
Wow.
because if they've habituated to the point where they're not bringing it up in a routine hearing test, I don't necessarily want to like um, revisit that neural pathway. It's like if you've tried to forget about an ex, I'm not going to ask you about your ex and say, "Oh, is your ex working? Like what are they doing?" And just kind of let that lie. But I would love to hear what Jim's comment was going to be about habituation. If we can get let's hear if his audio's.
We're not quite back yet. But it's odd because you were like mid-sentence and it just
How
dropped.
about
Oh,
now?
no, yes,
I don't
woohoo!
know what happened, but I got a little button here and I pushed it and now I'm back. So sorry about that.
No worries.
Yeah, I was talking about the TFI and different domains, and so you can get a
Yes.
different score depending on the domain, and so that kind of helps to determine, well, what is the main problem that the person has? And the method of progressive tinnitus management that we developed at the VA, if they get to level 3, that's called skills education, where we want to teach them skills so that they can self-manage their tinnitus on their own. So we're teaching them those skills. It's a combination of sound therapy or sound enrichment and cognitive behavioral therapy skills. And there's a lot of different skills that can be learned with cognitive behavioral therapy. But we would focus on what is your primary tinnitus problem. And if it's sleep, then they would write that on this form. And then how are they going to use sound to make their sleep less of a problem? And then how are they going to use CBT skills like relaxation, deep breathing, distraction, planning pleasant activities to improve their sleep? And they would fill out these forms. They would go home. They would try these things on their own. They would come back. So that was what our counseling was with progressive tinnitus management, and that generally helped most people. So they're not doing something that's not relevant to what their needs are. And a lot of treatments are just a one size fits all. Just do this, just wear this device, just listen to this sound. And with PTM, we decided the way to go is to figure out what sound works best for what patient in what situation, and what CBT skills work best for the patient in different situations. So we approached it that way. And again, habituation is it. That's the goal. We wish we could cure tinnitus. That would mean eliminating the sound or at least permanently reducing the sound. And we don't have any proven method to do that. So we have to use methods that reduce the impact of tinnitus on the patient's life. And again, it requires counseling and learning these different skills and self-management and trying to get to a point where you're not thinking about your tinnitus most of the time, and when you do think about it, you're not reacting to it in a significant way. And that's habituation, and that also requires acceptance. So if the third wave CBT now is really all about acceptance, and so if you talk to a psychologist who promotes third wave CBT, they'll say you've got to accept your tinnitus, and ultimately that's true. But telling a person that right off the bat can be problematic because it's like, what? Accept my tinnitus? I can't do that. But over time, yes, you can learn to accept tinnitus. But in the meantime, do whatever you need to do to just get through the day, get through the night, and not have tinnitus overpower your life. So it has to lead to acceptance and it has to lead to habituation. But in the meantime, people need to just learn strategies to live their life and have a normal life in spite of tinnitus that they feel is just driving them crazy.
Yeah,
I
great.
just want to chime in really quick because I loved all that. And I wanted to add, even if we could theoretically cure tinnitus, the body and the brain are very good at especially just who you are as a person, can be very good at noticing neural firings. And it can, so if you cure like one tinnitus, you can have another tinnitus that the body like and brain chooses to focus on. So learning these skills, even if we had a cure, learning these skills, I think is still going to be valuable because training the brain and the limbic system on how to manage these firings that we don't necessarily want to pay attention to. And this is why these techniques, there's a lot of overlap with techniques and methodologies that treat pain, depression, anxiety, because these are things that our body and our brain, and I feel, Sarah is much more equipped to handle this topic than I am. So I just want to, bow to her on that. But these skills, even if we did have a cure, having these skills is still going to be essential and valuable. And I tell people you don't have to wait for a cure. Like learning this now is going to be beneficial.
And Sarah, I feel like you have to chime in.
I do. So I was going to say that, there's an awful lot of people who experience tinnitus and it doesn't bother them at all. And and then there's the group of people who tinnitus becomes intrusive. And I really think that has to do with whether or not there was something that inhibited their body's natural process of habituation, that the body to naturally tune it out. And in my understanding of the polyvagal theory put forth by Stephen Porges, and that's what I use as another one of the frameworks for treatment in our office, is there's a process called neuroception, and that is a preconscious or subconscious process that happens in our nervous system where when a stimulus comes in, internal or external, then the neuroception process decides whether something is safe, neutral, or a threat. And if it's a threat, then it'll grab your attention because it might even do a light activation of your fight or flight. And so it's that, and I think of that as that's a bottom up process that we can't really think our way out of. And so that's where these breath work techniques and things like that come into play, where we have to not only, that's why these relaxation techniques and things like that are super important part of the tinnitus treatment process, because we have to help your nervous system feel safe. You have to feel safe in your body with your tinnitus. You have to be able to coexist with it with a neutral label. And so we can use some of those strategies in a very specific way to help your nervous system start to regard your tinnitus as a neutral, so that your natural habituation can just happen. And then you can join the group of people who have tinnitus but don't care at all, and they don't hear it, they don't notice it. They don't think about it unless just once in a while it'll come in and grab their attention. So just wanted to share that.
No, that's great. And actually, it a quick follow, and actually maybe Greg can touch on this too. Are these things that you can learn in a remote type of session, or do you have to be in person, or like what's the flexibility with this? And maybe Sarah, I'll have you go first, and
Yeah,
then Greg.
yeah. So definitely this can be done remotely. I do a lot of telehealth with patients who have an audiologist in another state, even, and they'll work with their audiologist there, but I'll jump on and do some of the mind body work.
Oh,
We
nice.
also teach mind body skills groups. The Center for Mind Body Medicine found that during COVID, it used to always be in person, but then they had to do it remotely. And they found that people were benefiting just as much remotely by learning mind body skills for regulating their nervous system. Uh, as just as well as they were in a
That's
in-person
wonderful.
setting. So absolutely, these things can be learned from a distance. Mhm.
Yes. Oh, that's great. Yeah. And Greg, I know that you might have, yeah, kind of a
Yeah.
similar or different experience. Yeah.
Yeah, so yes, remote, yes. And I wanted to share something I learned from Dr. Jennifer Gans, who does a lot of work with mindfulness and tinnitus management and publishes a lot of her work. And she, in a lecture I attended from her, she talks about people who meditate have develop a longer what's called a stimulus response gap. So there's a gap of time in which we experience a stimulus and then we respond to it. So lately, and I don't really like this I keep workshopping new metaphors. So this is like a B minus metaphor I'm about to give, but like if you walk into your kitchen and there's like a pile of dishes in your sink and you might get really upset like, well, I just did the dishes, why are there so many dishes in my sink? Like the stimulus would be seeing those dishes, and the response is like our body, like we get frustrated and then we might have a conversation we don't, that doesn't turn out well or whatever. But people who meditate and engage in mindful practices have a longer gap of time in which the body can process like this information of like you see the dishes and you don't react right away, and then you remember, oh right, I forgot, my partner's like out of town or something, I don't know, whatever. But like just what that those are skills that can be taught remotely, that don't have to be in person to learn these things. So yeah.
Thank you. Yeah, no, and it's good to remember, yeah, some of these, I always appreciate a metaphor to really kind of help us remember how we might be able to even modify some of our behaviors and have a better outcome for some of those conversations when you see those dishes pile up. So, I might switch gears because I realize we are having such a great conversation, and we have a few example kind of vignettes that I think would be helpful for people to hear this group respond to. So, we're gonna jump into a few examples, and we're going to focus on. In general, what would be kind of a minimum effective plan to kind of get this patient started? Where might this person kind of feel a little bit stuck? And generally, kind of what helps you move up or down in terms of where this patient needs to get either more or maybe we don't need as much care. So I'll just kind of read through a few of these vignettes. So our first example is Alex, who's 34 and went to a loud wedding. So I know that there's a lot of questions in the chat about noise exposure, so this might resonate with some people. So 2 weeks after a loud wedding and a stressful month at work, they noticed a high-pitched ringing at night, and they're sleeping okay, but they're kind of checking it constantly. They've been reading up on the internet with all of the resources out there and found some scary things. Now they're worried that they might be going deaf or might have a tumor. But their hearing feels totally normal, except that now they really want to get a scan, and then also they just want a cure. They want that sound to go away. What might be a good kind of first step for this person, that first visit, and yeah, kind of what might you think of as their journey next? And Jim, I might tag you first as someone who might give us a first step for this one.
I would say the first step is to meet with an audiologist, and ideally meet with an audiologist who specializes in tinnitus, and have your hearing evaluated. Even though you don't think you have hearing loss, you might have caused some damage to your ears, either at the wetting or a combination of noise exposures in different situations. Get your hearing evaluated. Have like I've said before, a brief tinnitus assessment. You don't need a comprehensive tinnitus assessment at that point. You need to have a good case history and you need to rule things out. You need to maybe be screened for anxiety, screened for depression, screened for insomnia. The audiologist needs to sit down with you and do an interview and find out, what's your life all about and what are your issues and how does that relate to your tinnitus. Evaluate your hearing and then make a decision. Do you need any further services, or are you good? And if it's a temporary noise in your ears, it'll resolve. It usually means some damage has been done, but it's a red flag that you need to really protect your ears in the future. So part of it is just learning how to protect your ears in the future so that that doesn't happen again. And that's a whole area of discussion that involves earplugs and earmuffs and how do you protect your ears. That is a really critical point for everybody, no matter what, but especially for the person who has early onset tinnitus and wants to know what's going on. To me, that's the starting point, is meet with an audiologist, ideally a tinnitus specialist, but really any audiologist is going to be able to help and determine if you need to go to see ENT. Do you possibly have symptoms that would indicate you need a physician to do an assessment? So that's the starting point.
That's yes, I love to hear that. And my thought is, how might we find that person to get that care? So tinnitus specialist, audiologist. So you would need to find kind of someone who provides that hearing education, hearing evaluation, and that tinnitus education as that first step to make sure you really do have all of that triage. Which, Jim, I know you a little bit well at this point, and I think that also speaks to increasing education for audiologists in general in this area of tinnitus. So we might touch on that a little bit
Can
later
I, can
too.
I mention
Yeah,
real
of
quick?
course.
So the ATA, American Tinnitus Association journal, the Tinnitus Today, has a list of providers in the back by state. So if you have that journal, if you're not a member of ATA, make sure you join ATA. I think it's what, $50 a year, and you get the journal 3 times a year. You get access to all the ATA resources, and that's a good starting point for getting information. But there is a list at the back of every journal with all the providers, not all, but a lot of providers in the United States and I think internationally who provide uh, tinnitus specialty services. So that's a good place to find out if there's somebody close to you who does specialize in tinnitus.
Yeah, that's a great reminder. And yeah, I think that's something that, folks could certainly tap into as a resource. There's also another set of kind of resources out there. So anyway, it's nice to kind of go back to the ATA and make sure that we're kind of getting those verified resources. So that's a good example. Um, I will kind of pop over to another example, which might actually touch on someone with a little bit more chronic needs. So I might toss this to Sarah after the example, just as a heads up. So for this one, Maria is 47. She's had tinnitus for 18 months, and it's not particularly loud in like a decibel sense, intensity level, but it's really affecting her sleep and her focus. She's starting to dread bedtime, and she wakes up thinking about it and kind of searching for it, and she's starting to kind of slip at work. So she's tried different things like white noise supplements and different tinnitus apps. She says, she's certainly not suicidal by any means, but she does say that she can't live like this. If this is how the patient is presenting to you at a first visit, how might you approach this as her kind of minimum next step? What to do in that visit and kind of what might you see as that first step? This one might be a little bit more of a journey. Um, yeah.
Yeah, this is a little bit more of a complex case. She's got a lot of areas where her life is being impacted. So, of course, we're always going to start with a really thorough assessment of case history. We're going to look at TFI scores. We're going to do the audiological exam just to find out what's going on in her individual auditory system. I'm curious about how people experience their tinnitus. So I do some pitch match, loudness match, those kind of things, just so I can kind of um, have a shared experience of, what does it sound like to you? And then I would do a lot of counseling and education once we kind of figure out what her particular auditory system is, what her function is, and we'll then know if we need to add amplification or sound therapy, what kind of ways can we stimulate her auditory system. And then in this particular case, I'm looking at how is her nervous system responding. So if we're having sleep interruption and we're having difficulty focusing, then we know that we're, you know, going back to Dr. Porges's framework, we're getting both dorsal, vagal, and sympathetic activation from her tinnitus. So we're going to want to help her regulate her nervous system with sound therapy and breath work to help her have a neutral experience of her tinnitus. And then of course, if there are mental health issues coming into play, sometimes when the nervous system has been hypervigilant for a long time, it ends up being chronic anxiety, or it might even move into some depression. Then we want to see if we can get some help from behavioral health so that we can move treatment along a little bit faster. I think that's a nice way to think about removing that roadblock to habituation when we've got this anxiety or depression that sets in. That a lot of times we have to get a little extra help to remove that barrier. So
Absolutely. Yeah, yeah. I think it also speaks to yeah, you're spending some time really understanding kind of the state of their brain and kind of all of those different neural connections and kind of what is activated and how can you really make sure that you're kind of calming things down and moving things forward in a way that's really effective for them. So I think that that makes a lot of sense. Um, I know we are I feel like there's more to talk about. So I'm gonna run through this next vignette and then Greg, I'm gonna toss this one to you. Um, so for this one, we have got Ken. He is 62 and he says that tinnitus is his primary issue. His spouse says that he's asking what a lot and is avoiding restaurants, but he insists his hearing is fine and he doesn't want hearing aids. And he mostly is okay during the day, but the evenings are kind of rough and he's starting to withdraw socially. What might you need to know about this patient? And then also, how might you navigate some of the hearing and tinnitus complaints maybe co-occurring here with his response to it as well?
Yeah, this one actually comes up quite a bit where there's this overlap of hearing difficulties and tinnitus difficulties. Um, the fun thing about the relationship between hearing aids and tinnitus is that hearing aids can be a source of sound therapy, which we want to do anyway. I people often look for like a magic sound or the right sound for them. And I mean, dating back to for a long time, Brooks and Balmer did study decades ago that about 2/3 of the people who use hearing aids experience a reduction in their tinnitus. And that is a good statistic for any sound therapy. So it is one of those things where I often tell people or advise them that even if they're not necessarily experiencing like a subjective issue with hearing loss, just using the hearing aids can potentially help them with their tinnitus. Generally, withdrawal and isolation is a an effect of hearing loss. Those statistics are very clear that people with hearing loss tend to withdraw from social interaction. So I will engage someone with that. Ken, in this example, I would let him know that. And kind of, the one of the things is that there a lot of times there's resistance with things like this. Like we want the shiny toy, and those kinds of treatments that we might see, in a headline or in an article. And that's understandable, but I try to um I don't know how quite to articulate this, but put it as kind of low stakes. Like we can try hearing aids, and we can do different things with the hearing aids. We know as audiologists we want to program them a certain way, that we know is going to be most effective. And sometimes for people with tinnitus, especially if they have loudness sensitivities, whether it's recruitment or hyperacusis, sometimes we can fit those hearing aids a little differently than we might normally and kind of work our way towards a goal. And I say, we start off low stakes, like we can try it. And then a lot of times those conversations end up shifting as people see that there are benefits from the hearing aids, that the conversations sometimes turn less from tinnitus and more to optimization of the hearing aid, which is a cool place to be because it means that that has become like the brain is not just solely focused on the tinnitus. So that can be a cool experience in and of itself.
Definitely. Yeah. Well, that's great to hear. Yeah, I think a lot of times we do kind of hop over the hearing aid step. As from like a patient perspective, I've seen some folks want to kind of jump into using our step care model, kind of a higher step, a more advanced or even more expensive step, when you might actually get a better benefit and expanded benefit, like from hearing aids, if you actually take one of those earlier steps. So I think that's a really good call out for that one. Um, I'm curious now that we've heard a few of these vignettes. I think we all know that there are certain ways that our care models can be different. We've talked a little bit about how the VA, private practice, and hospital systems might, approach things. I think we also have really thoughtful and experienced tinnitus practitioners on our call, so we're very lucky for that. I'm kind of curious about what what you might where might you think patients fall through the cracks in these different systems, and how might we, as a field, and maybe giving patients a little bit of a heads up, like how might we better support patients through these different systems when they're we're not all experts in the healthcare system, right? And we're all trying to kind of do our best with finding something that gets us to that habituation goal. What might come to mind in terms of something where a tinnitus patient might fall through the cracks and how they might get out of that again? I always think of that TFI as a way to check in, but I've moved my boxes around. I can't remember if it was Greg or Jim, but not necessarily putting out the TFI as something to offer as a regular checkup if they're not really, commenting on their tinnitus anymore. I'm curious about, if there's um, other ways that maybe we're supporting patients through our different systems or. Um, Sarah, I often think of private practices as something that has, an opportunity to have more, I don't know, of a catch for these patients because you might have access to more, technology or something to track them. But I'm curious, do you have like a program that patients go into, or how do you make sure they don't fall through the cracks?
I think that in private practice, one of the luxuries I think we have is time. I think that I've got and my audiology assistant is also a yoga teacher, and so she is really helpful with breath work because that seems to be the part that hangs people up a little bit in our practice when they're learning our active sound therapy protocol, that they forget to do the breath work. And so having so that's just in my own clinic, something where I see people fall through the cracks. But I think in general, in a larger sense, it's if I'm making a referral to another specialty like psychology or ear, nose, and throat, that making sure that they make the appointment, follow through, and then for me to ask for the information back from the other professional. Sometimes because I'm not in a system where I don't have just ready access to the ENT report after they go see ENT. I can't just look it up, or
Right.
it's not automatically shared with me, I should say. So I would say that's one spot where there's a little bit of,
Yeah.
but
Yeah. I might underline that actually, because I think we
yeah.
see that in other systems as well, where we see kind of that closing the loop communication can be a little bit challenging, especially when you're moving, between different specialties. And we know that that happens a lot in tinnitus, especially as we're talking about cognitive behavioral therapy, CBT, as well as these different referrals that we're talking about. So I think that's a really big one. I think actually you've just like hit the nail on the head. So communication is the thing that we really could work on to improve. Making sure that patients kind of get that care. So thank you. That's really great. Um, yeah, I know we're kind of at the top of the hour, so I wanted to kind of close with a few not quite one-liners, but kind of like some overall thoughts. And I know that in general, there are maybe some myths that we come up with as we're looking through the internet, and we might find some misconceptions out there. I'm curious if there is any particular um, misconception that might come to mind that you would like to offer, something else for our attendees today. I often think about Greg because he has a lot of these ways that people might think about tinnitus and kind of thinking about it differently, actually using essentially a cognitive behavioral therapy technique to kind of replace that type of message. But I'm curious if there's something that that comes to mind for our tinnitus patients that they often come in and say, "Well, I know this to be true," and you might offer something different. Um, there could be a long list, so this could be something that requires thought. um, but feel free to unmute. I wonder if Greg might have a first thought. Yeah.
Sure. Yeah, there's, like you said, there are so many. I think the one thing is the kind of the concept of, or the catastrophizing of what damage means. So they go, I am irreparably damaged. This is something is inherently wrong with me. And we as humans go through wear and tear. They did some really interesting studies with sound exposure for people who live in urban areas versus like remote rural areas that don't have technology like in the world. And we as humans just we go through wear and tear. And sometimes the way that the body locks onto some part of that wear and tear, whether it's your knee, your nagging knee, or the ringing in your ears. And I think that um, there even if something has happened to the auditory system now, and to go to Jim's kind of like there's always something we could do about it going forward. So like protecting our ears. I tell people that being exposed to noise is like putting trash in a trash can, but like we can't necessarily empty it out, but it's never too late to put the lid on the trash can, and just like prevent more trash from going in. So it's so trying to help like steer people from these kind of either catastrophic thoughts or on the flip side of like I'm an electrician, and if there's a wire broken, then I fix the wire. Like if there's a wire broken in me, like why can't we fix the wire? Or we've done all these things with science, why can't we do this? And the brain doesn't work like that. There's a lot of redundancy. It's not a circuit board that we can pull out and test each circuit, because even if it were, there'd be thousands of circuits repeating similar messages. And I don't want to create new catastrophizing, but as we learn more about these neural pathways, there's there is more there are things we can do, and just trying to help reframe things for people, because we tend to get one piece of information and then our brain like launches off from that, and it's like, well, let's time out. Yes, we have a piece of information, but then we can go forward with that.
Yeah, definitely. It's yeah, I feel like that is uh yeah, you've really I love that. I yes, exclamation point. Yeah, and I guess you know, just to kind of start kind of closing here, we've got we'd like to ensure people have tools to kind of bring their thoughts into a better place and kind of reset kind of this nervous system a little bit. Um, I'm curious if we've got maybe one takeaway either for patients or for clinicians, or if you have one for each, that is okay too. But one takeaway that people who are attending today should kind of remember and bring with them. It might be something like what Greg was saying, kind of thinking about some of these thoughts differently. But I'm curious if there's one thing that you wanted patients or clinicians to take away from today's session, what might that be? And Sarah, I see that you're like ready to go.
Yeah. Well, mine would really, for clinicians, if there's clinicians on this call and you have interest in tinnitus, please get training and join us in this specialty. We need more of you. We need more of you.
Mhm.
We need more people on that list that ATA has um, in more states. That was one thing as my time as the interim director of the ATA while we were searching for our wonderful leader, Patrick, was that there's not enough of us. There's not enough of us who are ready, willing, and able to give quality care to tinnitus patients. And also, that tinnitus is a multi-system phenomenon. So there's not one, we can't just treat it from one avenue. We have to come at it with auditory and top down and bottom up processing. So um, that would be my last takeaway. So please
Yeah.
join us.
Yes, yes, join us. Yes, we do need more folks who have more training and are able to truly receive that patient and kind of guide them from that first start. There are tools available today, but I think we also need more tools. So anyway, I will, and maybe I will toss it to Jim to hear your thoughts about one takeaway from today for either patients or clinicians.
Well, ditto for what Sarah just said.
Yes.
Clinicians need training, and unfortunately, AUD programs and psychology programs don't provide training on a consistent basis. And so providers need to be self-trained. And there are many resources out there, but the person has to be motivated. They have to want to learn and take advantage of the resources that exist. And I've been posting on LinkedIn different resources, and I'm glad to provide that list to anybody who wants it. Also for patients, protect your ears. Some patients feel like, well, I've already got hearing loss or I've already got tinnitus, so it doesn't matter anymore. Well, it does matter because you're going to continue to lose hearing, continue to possibly make your tinnitus worse, maybe get loudness hyperacusis, and so it matters a lot. Carry earplugs with you everywhere you go and use them whenever sound is uncomfortably loud or loud enough that can cause damage to your ears. And just make that a routine. Put them in your pocket along with your car keys or whatever. That's the main thing. And get educated. Make sure you know about tinnitus and you understand tinnitus before you start embarking on receiving services and spending a lot of money.
Yes, that's, I think, great guidance. And yeah, I think wow, there's like so much I could touch on there. But yes, I will just also underline, making sure that embracing kind of this stepped care model is helpful also for many reasons, but also financially. A lot of these things can be very expensive the higher you move up on this ladder. And so if you can, get something that helps you out, that's kind of at that a more baseline entry level and also gives you other benefits, like isn't that wonderful? So you've said a lot there, Jim, but I wanted to just underline that piece. So thank you. That's a lot of great takeaways there. Greg, yeah, what do you think that either patients or clinicians might want to take away from today's session?
Yeah. So for clinicians, again, like don't be afraid to counsel on tinnitus, and practice it. It just takes reps of like explaining it. I think we're scared of things that we don't know how to answer very well. But if you practice what you do know and share with people, you can kind of, you know, stem like dam that river a little bit, because there are times where I'll get someone who was told by an audiologist like years ago that, well, you just learn to ignore it or something. And there's more to it than that. So I think if more audiologists were able to talk about tinnitus, then it could kind of stem the tide a little bit and just not let people kind of progress for so long. And then for patients, there, just to touch on what Sarah started this with, is there's always hope. There's always things we can do. The skills that we learn are going to be useful. It does, for now, it does take patience, and it's hard. I mean, we all want help, in that. It's like I've been patient, I've tried. We want help, and we do have tools. And I understand there was someone on the call either earlier or now who was trying to actually to get into our clinic and seemed to hit roadblocks at UCSF. But don't stop asking for help and care. Start with a hearing test. Ask your primary care, I need a hearing test. I want a hearing test. And then ask for specialties, and say, I need to talk to someone just for tinnitus. And don't stop that process.
Yeah, yeah. And it's interesting because I think a lot of times when you have someone with tinnitus come into your, audio, your hearing test appointment, um, if you're not necessarily trained to work with people who have especially bothersome levels of tinnitus, you might kind of treat it as, oh, I'll just kind of tell you, kind of some basic information. But something that I was reflecting on recently is, this is a very personal experience for them, and they will remember that first, moment of, I had this interaction. I told a healthcare provider about my tinnitus, and this is what they told me, and that is what they will take with them. And so, being able to really communicate clearly and effectively about the options that are available, and not necessarily, defaulting to, oh, you'll learn to ignore it, or oh, you just don't think about it. Really kind of perfecting that little speech that you give to make sure that they take that away to, as Greg said, stem the tide. Because I think that moment is more critical than we might imagine. So I think maybe my takeaway, kind of bringing all of this together, might be, if tinnitus is affecting your quality of life, if it is something that continues to bother you, seek help and seek appropriate help and look for these tools, through the ATA, through, respected institutions, because they are out there and, we want to help. So we just need to get connected. Um, I just wanted to kind of wrap up here. I know we're kind of past the top of the hour. We got a little bonus time with our panelists, so thank you so much to everybody. I wanted to just remind everyone that this was, put on by the American Tinnitus Association, and we're really grateful for all of the resources that they, put out for us over, the last several years and decades. This is something that, if you've found value in this, we would love to hear about it. I know we're going to follow up with a survey so that people can kind of let us know what was helpful, what you'd like to have improved for the next one, because I think we're getting a lot of kind of positive comments about this type of webinar. So thank you to everybody who joined us today. Thank you for all of the questions. I know that we didn't get to all of them, but we will definitely try to kind of keep those in mind for future sessions. Dr. Henry, Dr. Downs, Dr. Hobbs, thank you so much for joining us. It's just been a pleasure. You're just wonderful to chat with, and I wish we could have all day, but I guess some of us are going to watch this some sort of sports ball later, and that'll maybe be some fun for us too. All right. Well, thank you again. Have a great rest of your day, and please do visit the ata.org website if you need more information. If you didn't register for the seminar, we'll send out this link to those who were registered. So I think, go back to that registration link to make sure that you get all that information. All right. Thanks again. Thank you, Dr. Henry, Dr. Downs, Dr. Hobbs. Have a great rest of your day, and we will see you very soon. Take care.